First of all, we'll start with the tuberculosis guidelines. We're going to read it from the pediatric guideline and from the neonatal guideline book as well. So first of all, how to recognize and assess. So history is the most important factor in diagnosing tuberculosis. We have asymptomatic high-risk children. They don't have symptoms, but they still at high risk. Child who is in contact with TB case, for example, from a country with prevalence of more than 150, more than 150 over 100,000. And they put a link here just to have a look on it later. Increased susceptibility. For example, his age less than 2 years old. He has immune compromised system, including HIV children. They taking steroids. They are treated with anti-tumor necrosis factor biologics. Refer to TB team for screening for latent TB. So that's the list of asymptomatic, but they have a high risk. So again, they have a contact with a TB case from a country. They migrate from a country with a prevalence of TB more than 150 in 100,000. They have increased susceptibility to catch TB in ages less than 2 years old, immune compromised, including HIV. Taking steroids treated with anti-tumor necrosis factor. They have other high-risk group, which are those who are referred to the TB team for screening for a latent TB. Okay, what are the symptoms of TB? Suspect TB when following symptoms persist for weeks. Persistent non-remitting cough for 2 to 4 weeks. So we have persist, non-remitted, not improving cough for 2 to 4 weeks. Weight loss, failure to thrive, lack of energy, fever and sweats, lymph nodes, especially if painless and matted altogether, headaches or irritability for more than 1 week, limb stiff back, joint swelling, abdominal distension. Symptoms may be non-specific in infants, increased susceptibility. Okay, those are the symptoms. I guess all of us know these symptoms. Let's go to signs. Delayed growth, plot weight and height on growth chart and compare with earlier records. If he has previous or past records, we have to compare. Fever, wasting, lymphadenopathy, chest signs, cardiac tamponade, ascites, meningism, ophthalmoplegia, which is weird to be exist with the TB, but put this in mind, ophthalmoplegia, conjunctivitis, limited flexion of spine as well, kyphosis, swollen joint, cold abscess. Okay. Family and social history, which is very, very, very important. Ask about travel and about recent contact with any family member, specifically grandparent or parent, who has chronic cough, previous treatment for TB, especially multi-drug resistant, MDR TB, failed defaulted TB treatment, or recurrent TB. So that's very important. So travel and recent contact with a family member, which they may experience a long period of chronic cough, resistant to treatment, multi-drug resistant, previously failed to respond to the TB treatment, or they have a recurrent TB. Travel to regions, countries with a high prevalence of TB, or MDR-TB, or recently died because of TB. Okay, let's move to the investigations. Suspected, if we have suspected latent TB, so what should we do here? So we have to ask for tuberculin purified protein derivative skin test, which is Mantox, and that's the very famous name that we know about it. Interferon gamma release assay, which is IGRA. The brand names are Quantiferon TB Gold or T-Spot TB. Positive results are not diagnostic of TB disease, and negative results do not exclude it. These tests may still be useful as part of the overall picture in symptomatic children. Tuberculosis, page 2. So suspected TB, if you have suspected TB or active TB, discuss with expert in pediatric TB, even if rapid diagnostic test AFB and BCR and TST or IGRA are negative. So suspected TB, that means the patient is symptomatic. So you have to discuss with an expert in pediatric TB, infectious team. We have to do rapid diagnostic test, which called AFB and BCR, and TST or IGRA are negative, even if rapid diagnostic tests are negative. Okay, so first of all, let's say that we have a pulmonary TB in here. So first of all, we're gonna do chest X-ray. I'll ask for sputum. Okay, let's take it one by one. Chest X-ray, look for hilar lymphadenopathy, apical consolidation, pleural effusion, miliary nodules. That's what I'm going to look for in the chest X-ray. So hilar lymph node, apical consolidation, if there's any pleural effusion, and miliary nodules. Sputum, send 3 or more. One early morning for AFB and TB culture in cooperative child. Expectoration may require physiotherapy plus minus nebulized sodium chloride 0.9% as necessary, with FFP3 mask and HEPA filtered ventilation if available. If unable to provide sputum specimen, send gastric aspirate for TB culture only as microscopy is unreliable. Early morning before feed, daily for 3 days. Okay, so first of all, let's repeat again. So we'll ask for chest X-ray. Second, we will look for a sputum sample, which is, we need 3 or more sputum sample. We get one early morning for AFB, which is acid fast bacilli, I think. And TB culture in cooperative child. So this needs a cooperative child to obtain this kind of sputum sample. Expectoration, need a physiotherapy, nebulized saline, stuff like that. Okay, if we couldn't get a sputum sample or a specimen, we have to move to the gastric aspiration. We send it for TB culture only as microscopy is unreliable. Okay, if we send it for just microscopy, not culture, it won't be reliable to diagnose. So this is gonna be early morning before feed over 3 days. And every day, early morning, we have to get a gastric aspirate once he get up from sleep, I guess. If no, aspirate, rinse his stomach. Okay, so and then okay, so we said if no aspirate, I tried to get a gastric aspiration, but I couldn't to get it. If no aspirate, rinse the stomach with a small volume of sodium chloride, 5 ml Alcott, maximum 20 ml. Do not send saliva. Okay, discuss bronchoalveolar lavage for AFB and TB culture via bronchoscopy with respiratory consultant. So I will try something else, which is bronchoalveolar lavage. If I couldn't get gastric aspiration, so I will move to do a bronchoalveolar lavage for AFB and TB culture, but I have to consult my respiratory consultant first. I will not do that by myself. Request 1 TB BCR test per specimen type in addition to AFB and culture. So I will do a TB BCR test per specimen. Okay. So that's basically what we're gonna do. If we have a pulmonary TB, so that's just X-ray, obtaining sputum, whether by expectoration in cooperative child or by gastric aspiration or by bronchoalveolar lavage. Okay, so and I will do 1 TB BCR for bear one specimen. Okay, if we have a pleural effusion. So first of all, I will do chest X-ray, preferably BA erect film. So that's postero-antero erect film. 3 respiratory sample, deep cough sputum, induced sputum or gastric aspirate, pleural biopsy for histology and microbiology, AFB, MTB, PCR and TB culture. So chest X-ray, BA erect film, 3 respiratory sample, deep cough sputum, induced sputum or gastric aspiration, pleural biopsy for histology and microbiology, pleural fluid, AFB, MTB, PCR, TB culture, cytology, adenosine deaminase. Cytology and adenosine deaminase. Discuss with cardiothoracic surgery. So I have to discuss with cardiothoracic surgery team as well in case of pleural effusion. Okay, so that's chest X-ray, pleural biopsy for histology and microbiology, pleural fluid aspiration as well, sample for cytology and adenosine deaminase, as cytology and adenosine deaminase, and discuss with cardiothoracic surgery, lymphadenopathy. If I have lymph nodes, if single node, excision biopsy. So if I have only one single node, I will do excision biopsy. If large matted nodes, ultrasound scan, plus minus simultaneous guided aspiration, discussed before scan. Okay, so if I have only one single node, I will do excision biopsy. If I have large matted nodes, so I will do ultrasound scan plus minus simultaneous guided aspiration. I have to discuss before doing this scan. Lymph node aspiration, fine needle aspiration biopsy, 23 G needle. Okay, low risk, high yield with sedation and local anesthetic. Send aspirate in 2 separate bottles, 1 to microbiology for AFB, TB culture, and PCR with no preservative, 1 to histology, 10% formalin. If atypical mycobacterial infection suspected, we do excision biopsy. Okay, so again, I will repeat again this section. Lymphadenopathy, if we have single node, we will do excision biopsy. If you have large matted nodes, so I will do ultrasound scan first, plus minus simultaneous guided aspiration. I will discuss with my consultant before that. Lymph node aspiration, which is called fine needle aspiration biopsy. If there is a low risk, high yield with sedation and local anesthetic, send aspirate in 2 separate bottles. So I will have 2 aspirations, basically, 1 for microbiology and the second for histology. If I'm suspecting atypical mycobacterial infection, so I will go straight away to excision biopsy, but keep in mind, for all that, I have to discuss with my consultant, with the infectious team, with the TB team as well. Okay, meningism. What if I have a patient presented with meninges, TB, meningitis? So first of all, I will ask for MRI, preferred CT if general anesthesia required, but too sick to tolerate. Okay, so MRI is the best. We may ask for CT if general anesthesia required, but too sick to tolerate. Okay. CSF sample for AFB TB culture, cytology, PCR, adenosine deaminase requires 4 ml of CSF for PCR. So PCR needs a quite enough amount of CSF, which is minimum, I guess, 4 ml. Okay, what if if the patient has a bone or joint pain? What should I do? So basically, I will do plain X-ray, initial imaging modality. I will do just plain X-ray. CT and or MRI may be needed to evaluate extent and bone destruction. Discuss with pediatric radiologist. So if he came in and he is known case of TB, he has some sort of bone pain or joint pain. So basically, what I'm gonna do as a registrar position, I will ask for bone or for plain X-ray. That's what basically ask for. Then I may think for to do a CT and or MRI if needed, but I will discuss with the pediatric radiologist first. Biopsy aspiration important for diagnosis and sensitivities, so bone biopsy and aspiration as well, or there's a lesion visible to me after doing the X-ray and MRI, I guess, or CT. Spinal TB, if I'm suspecting there's a spinal TB, so I will do LB as well. Okay, abdominal distension, ultrasound, then a CT abdomen. I'll do ultrasound abdomen, then a CT abdomen. If there's ascites, bowel or ascites, bowel lymph node biopsy, AFB, PCR, TB culture, cytology, adenosine deaminase. Okay, if there's ascites or bowel lymph node biopsy, okay. Biuria, if we have a patient with biuria, pus in the urine. So basically, I will do urine analysis. If blood and leukocytes present, send for PCR and culture. So first of all, I will do urine analysis. I will do the sticking, basically, as simple as that. If I've got blood or leukocytes, debris, traces, I will send for PCR and culture. Non-tuberculous acid fast bacteria common in urine. Okay. Ultrasound kidneys. I will do ultrasound of kidneys as well. Early morning urine culture. Early morning urine culture. So if we got urinary symptoms from that patient, I will do urine analysis. If there is any blood or leukocytes, I will send for PCR and culture. I will do ultrasound scan for the kidneys. I will ask for early morning urine culture. Okay. What about the pericardial effusion? Pericardial effusion. I will do echo, basically, pericardial fluid, AFB, TB culture, and PCR cytology and adenosine deaminase. Disseminated, including miliary. Disseminated, including miliary TB. I will ask for CT scan thoracic and ultrasound abdomen. Lumbar puncture, CT or MR. First, if seen is signs or symptoms. Bronchial wash. So disseminated miliary TB, that's mean most of the body organs are involved. So we will do a CT scan, chest, ultrasound, abdomen, lumbar puncture. Before lumbar puncture, we do CT or MRI first. If there's any seen as symptoms, we do bronchial wash as well. Okay, we do blood for TB culture, blood sample for TB culture, bone marrow biopsy if diagnosis is uncertain. Okay, immediate management. What should we do in here? Discuss treatment with the local TB team. So before I think to start any treatment, I have to discuss the treatment with the local TB team and lead pediatrician for TB. If clinical signs and symptoms consistent with diagnosis of TB, start treatment. Do not wait for culture results. Send specimen for microscopy and culture before starting treatment unless life-threatening disease. Inform public health through TB nurse team. It's infectious disease and it's one of the notifiable diseases. So this is very important to keep in mind that we have to inform public health through TB nurse team who will organize chest X-ray and Mantox IGRA for all close and visiting contacts. Inform infection prevention team as well is very, very, very important. Infection prevention team advise anyone with cough to avoid visiting ward. Admission not mandatory but useful to ensure adherence with treatment. So admission here it's not mandatory at all, but useful to ensure adherence with the treatment. If supervision can be guaranteed, allow treatment at home. Contact TB nurse team before discharge. So it's better to keep the patient in his own home. That's a kind of prevention, infection control measures, which is very, very useful. If he can take his medicine at home and he is sticking very well to his treatment, that's will be very useful to it's kind of infection control. If sputum positive and hospitalization necessary, strict barrier nurse in single room for 2 weeks or until discharge. So this patient will have only one and single nurse who is nursing him. This nurse cannot share this stuff between other patients. She cannot visit other rooms or other cubicles. So that's kind of infection control, which is very important in this kind of type of infection. For 2 weeks. For 2 weeks. Okay, patient should wear a surgical mask if leaves room. Masks, gowns, and barrier nursing unnecessary unless MDR, TB or aerosol generating procedure. Negative pressure room for aerosol generating procedure, FTB considered. Okay, FTB considered nebulizer. Okay, so negative pressure rooms, I guess it's not available in the whole hospital, in all hospitals. So just keep in mind this. Okay, treatment. Refer all cases of suspected or proven TB, Mycobacterium TB to pediatric infectious disease team. So I have to refer the all cases of suspected, not even, I'm not even sure whether it's TB or not, but it's a highly suspected case, or proven TB to a pediatric infectious disease team. If contact with the drug-resistant TB, discuss with the pediatric infectious disease team before starting any treatment. So if the patient has a drug-resistant TB, so I cannot change any medication from my mind. I have to ask my consultant, or I have to discuss with the pediatric infectious diseases consultant or team. Liquid formulations. Okay. So we have a couple of medications we use in treatment of TB. We have rifampicin, isoniazid, and pyrazinamide. So rifampicin, that's 100 milligram for every 5 ml. Isoniazid, 50 milligram per 5 ml. Pyrazinamide and ethambutol liquids made as special formulations. For tablets, isoniazid tablets, oral dispersible tablet, rifampicin as well, capsule in form in concentration of 300 milligram, pyrazinamide as well in 500 milligram, ethambutol tablets in 100 milligram and 400 milligram. Combination tablets in the UK, so that's very helpful. The combination tablets, we have what we call it's Rifina, combination between rifampicin and isoniazid. That's 150 to 200. Other combination, rifampicin isoniazid, 300, 150. So the first one is 150 for 150, 100. The second combination, which is a bit stronger, 300, 150. Rifata, which is rifampicin, isoniazid, and pyrazinamide. Rifampicin, isoniazid, and pyrazinamide. So the concentrations is about 120, 50, and 300 for pyrazinamide. Okay, we have four active, rifampicin, isoniazid, pyrazinamide, and ethambutol. 4 combinations all together in one tablet. And I guess that's pretty awesome. And this will help the patient not to take too much medication. It's only 1 tablets he can take. Okay, WHO recommends treatment with dissolvable FDS, not always widely available in the UK, plus separate ethambutol where required. Okay, so that's what WHO recommend. It's dissolvable, so you can dissolve it in a water, I guess, or in juice or whatever. But we have to add ethambutol in separate. It's not involved in this. Okay, so we have rifampicin isoniazide, which is 57 to 50. We have rifampicin isoniazide bezinomide, which is 57, 50, 150. So we have to add on this ethambutol, which is 100 milligram tablets. Okay, so this table shows basically combinations or the concentration of the anti-TB drugs. So I have isoniazide, rifampicin, bezinomide, ethambutol. So isoniazide, we have 10 milligram per kg, maximum 300 milligram, rifampicin 15, maximum 600, bezinomide 35 milligram per kg, maximum 1.5 gram. For body weight less than 50 kilogram, maximum 2 grams for a body weight more than 50 kilogram. Ethambutol 20 milligram per kg. Okay, so BNF recommends maximum total daily dose of 450 milligram for less than 50 kilo, while WHO recommends up to 600 milligram for all body weights. Okay, so let's just keep in mind this note. So BNF recommend the maximum dose, it's 450 milligram for body weight less than 50 kilo. WHO recommends maximum dose 600 for all body weight. Okay. The duration of therapy. If the patient got a latent TB, if got a latent TB, so he will get RH 3 months or H 6 months or R 4 months. So what does it mean RH? H or R? Okay, so for latent TB, so RH mean R is rifampicin, H it's isoniazide. So latent TB will take rifampicin and isoniazide for 3 months, or isoniazide for 6 months, or rifampicin 4 months. So that's if he has a latent TB. He is asymptomatic, but when you do a chest X-ray, you will find signs and something in the chest X-ray, but he is not symptomatic. That's what we call latent TB. So latent TB will take, he will start taking the rifampicin isoniazide for 3 months. This is a combination of 2 medications, initially for 3 months, or he can take isoniazide only for 6 months, or rifampicin only for 4 months. Okay, non-CNS TB. So the patient has a TB and it's confirmed, but he doesn't have CNS TB or any central nervous system symptoms. So he will take rifampicin and isoniazid for 4 to 6 months. First 2 months, he will add ZE, Z, which is pyrazinamide, E is ethambutol. Okay. Okay, so that's if he has no any central nervous system symptoms. He doesn't have any TB in his CNS. So rifampicin isoniazid 4 to 6 months. During this period of time, he has to take in the first 2 months pyrazinamide and ethambutol. Okay, if he has CNS symptoms or CNS TB, he will take rifampicin isoniazid up to 12 months. First 2 months, he will add pyrazinamide and ethambutol. And there's up here, there's a link to have a look on the guideline on the NICE guideline website. We have a look on this later. Just to save our time. So again, the duration of therapy, if you have latent TB, he will start rifampicin isoniazid for 3 months, or only isoniazid for 6 months, or only rifampicin for 4 months. If he has no CNS symptoms, he will take rifampicin isoniazid for 4 to 6 months, the first 2 months, pyrazinamide and ethambutol. If he has CNS symptoms, he will take RH for 12 months. First 2 months will add pyrazinamide, ethambutol. Okay, this is timetable showing the body weight, the types, brand names of the combinations that we have gone through first in the previous page. You can have a look at this in your spare time. We don't want to waste our time on that now. We have this adult BNF dosage for the combination, Voractive that's containing the 4 tablets altogether according to the age. For adult, it's not according to the body weight as in pediatric age. Okay, let's move on. Okay, and here we have to add pyridoxine 10 milligram and neonates 5 milligram to prevent isoniazid neuropathy. So this is very important. So for neonates, newborn babies, we have to add pyridoxine 10 milligram. 10 milligram. For neonates, we give 5 milligram concentration. That's to prevent the isoniazid side effect of a neuropathy. If you have pericardial TB, add prednisolone. So we have pericardial effusion or pericarditis due to TB. So we have to think about steroids, prednisolone, 1 milligram per kg per day. Inform patient parents of both common gastrointestinal upset, rash, and are rare but important side effects. Staining of secretions, signs of hepatotoxicity as well. We have to inform the patient himself and his parents, his caregivers, about the possibility of staining of secretions, his urine, his saliva, whatever that may stain his pillow, his clothes, whatever, and signs of hepatotoxicity as well. Advise patients, parents, and GB of indications for seeking advice. If you got fever, malaise, vomiting, jaundice, or unexplained deterioration, consider coexistent viral hepatitis. Viral hepatitis may be coexistent with the TB itself. If AST alt level raises to a 5-fold normal, stop treatment and seek advice re-alternate regime. So if the liver enzymes, which is AST and ALT level raises to 5-fold normal level, we have to stop the treatment immediately and seek advice to think to change this kind of regime of treatment. Subsequent management. What should we do as extra investigation? I have to do HIV test after consent, taking permission from the patient and his parents, HIV test as well. So we have to check the HIV testing guidelines as well. Other drugs may be necessary once sensitivity is available. If resistant, seek specialist advice. Okay, so how we can monitor the treatment. If baseline ALT and AST or ALT AST raised but less than 2-fold normal, repeat at 2 weeks. If failing only, recheck if fever, malaise, vomiting, jaundice, or unexplained deterioration. If ALT and ALT, AST more than 2-fold normal, monitor weekly for 2 weeks. Monitor weekly for 2 weeks, then 2 weekly until normal. Check viral hepatitis serology. Stop treatment only if more than 5-fold normal. If on ethambutol and unable to report visual problem, check visual evoked response. So ethambutol may affect the may cause blindness. If the patient taking ethambutol and unable to report visual problem, check visual evoked response. Okay, discharge and follow up. If tolerating treatment and adherence guaranteed, discharge immediately. If TB meningitis or concerns about adherence will need direct or video observed therapy organized through TB nurse team. Review to ensure adherence. Review to ensure adherence at least monthly for first 2 months. So review to ensure adherence. Very important to make sure that your patient stick to his medication, especially if he was a TB meningitis and he's been discharged. So the TB nurse will follow through that. At least monthly for the first 2 months of the treatment. Okay, 2 monthly until treatment complete. So she will follow through the first 2 months and then every 2 months until the treatment complete. For 3 months after end of treatment and following for 3 months after he stopped his medication, further as clinically indicated. Okay, for latent TB, asymptomatic, close contact with positive tuberculin test or IGRA, or aged less than 2 years with index case with pulmonary TB, or new entrant from high incidence country with positive tuberculin test or IGRA. So that's what does it mean, latent TB. So he is asymptomatic, close contact. He has a positive tuberculin test or IGRA, or his age less than 2 years, with index case with pulmonary TB, or he is a new entrant from a high incidence country with positive tuberculin test or IGRA. If immunocompromised, discuss with TB specialist. If treatment for latent TB indicated but not taken, chest X-ray and clinical review at 3 and 12 months. If treatment for latent TB indicated but not taken, so we have to do a chest X-ray and clinical review at 3 and 12 months. If treating for latent TB, test for HIV, hepatitis B and C. If treating for latent TB, test for HIV, hepatitis B and C. Okay, neonate with contact with respiratory TB. Assess for active disease. I will check whether he has active disease or not. Treat with isoniazid for 3 months, then Mantox. So first of all, I will treat him with isoniazid for 3 months, then I will do a Manto. If he has a size of more than 5 millimeter, reassess for active disease. If not active TB, continue isoniazid total 6 months. If less than 5 millimeter, IGRA, I will do IGRA. If both negative, stop isoniazid and refer to TB nurse team for PCG. If positive, reassess for active disease. If not active TB, continue isoniazid for total 6 months. So that's for the neonate. Okay, so neonate with contact with respiratory TB, assess for active status first, active disease, treat with isoniazid for 3 months, then do Mantox. If 5 millimeter or more, reassess for active disease. If not active TB, continue isoniazid totally for 6 months. So first of all, we start isoniazid for up to 3 months, then do Mantox. If the size of the lesion 5 millimeter or more, reassess for active disease. If not active, I will continue treatment for 6 months. If less than 5 millimeter, I will do IGRA. If both Mantox and IGRA negative, stop isoniazid and refer for TB nurse team for BCG. If positive, reassess. If positive, reassess for active disease. If not, continue isoniazid for up to 6 months. Okay, if aged, if age more than 2 years, I will do Mantox. His age, the patient age more than 2 years, I'll do Mantox test. If 5 millimeter or more, assess for active TB. If not active TB, treat for latent TB. If less than 5 millimeter and contact smear positive. If less than 5 millimeter and contact smear positive, after 6 weeks, repeat Mantox and do IGRA. If less than 5 millimeter and contact smear positive, after 6 weeks, repeat Mantox and do IGRA. If both negative, stop isoniazid. If either positive, assess for active TB. If not active TB, complete treatment for latent TB. Okay, so we have finished the TB guideline from the pediatric, from the new pediatric guidelines. I hope you find this video very useful for you. And if you like this first video guideline, please like and subscribe for the channel. And I will upload the updated guidelines if there's any changes happened recently to any guideline, it will be updated on this channel. Thank you very much.